Hello. If you want to unmute. Oh, so green is good. That makes sense. Okay. Uh, so the amount of CO2 that you produce per oxygen consumption depends on what you're actually consuming, whether you're consuming protein or fat or carbs. That's respiratory quotient changes. If you remember 0.8, that's kind of like an average between 0.5, I think, is it for protein and 1 for carbs. So kind of related to nutrition in that way. But we'll talk about this a little more later. This Fick equation, this is kind of what we use everything for, right? What we're using to calculate VO2. And when you break that down, we can get some more nitty gritties. And then it's important we understand what the anaerobic threshold is. So this is when your metabolic demand exceeds oxygen delivery to the muscles. Now that's debated, but we'll talk about it a little more later. So what actually happens physiologically is lactate levels rise, and the ratio of lactate to pyruvate based off metabolism and what's happening through the Krebs cycle and glycolysis, all that, it tends to rise. So let's get a little more into the nitty gritty of it. Now, these are not absolute values, but it's meant to represent trends over time. So if you have your minute ventilation, your production of CO2, your production or consumption of oxygen, lactate, bicarb, pH, and end tidal CO2 is what they're measuring here. Okay, so in a typical human, you're producing less CO2 than you're consuming oxygen. And your minute ventilation, as you start exercising, does not increase as rapidly as the production and consumption of CO2 and oxygen. So those ratios you'll see later on a graph will give us some information. So you start off exercising, you're going to start consuming more oxygen, producing CO2. So both the oxygen consumption and the CO2 will start to rise here. And then eventually you'll get to some magical point where you no longer can use solely anaerobic respiration. Okay, so there's actually not evidence to support that this is because anaerobic metabolism is the reason why the lactate starts generating. Some people theorize that it's maybe the oxygen delivery is not being there, the oxygen is not actually delivered fully, or that there's a critical point in the PaO2 where below a certain threshold, lactate starts to be generated. But you don't really need to know that. At some point, you start exercising and you generate lactate. So that lactate gets buffered initially by your bicarbonate, and you start producing, as you buffer here, you start producing CO2. So now not only your muscles producing CO2, but lactate is being converted into CO2. So you're producing CO2 quicker than you're consuming oxygen. So that starts increasing right at this threshold. And you can see these lines kind of get a little bit different. And now since you're producing more CO2, your body's trying to maintain a steady pH, you're going to increase your minute ventilation. So you can see here, this also starts to kick up right at this magical anaerobic threshold. Okay. All right. So then it gets to a point you continue exercising, you're continuing to increase your oxygen consumption, and then you run out of bicarb to buffer your lactate. So now you're not able to maintain a relatively steady pH. That's this point here. So your pH starts to drop off, your bicarb drops off, your lactate starts rising more rapidly because you don't have anything to buffer it. You start becoming more acidotic, like we said. Because you're acidotic, you're going to increase your minute ventilation even more. That's this takeoff up here. And in a normal person, eventually you get to a point where your lactate builds up, you start having muscle pains, and you can't exercise anymore, and you terminate exercise. All right. That respiratory exchange ratio that we talk about, the production of CO2 divided by VO2, you can see here that if you're starting out before exercising, if you just look at the difference here compared to the difference at the end of exercise, it's much larger. So when you divide those products at the beginning of exercise, that number will be smaller than when you end exercise, if you really get far into exercise. Okay, so eventually that number will maybe go from 0.8 or so if the respiratory quotient is exactly right from that equation to something more positive over time. Okay. And a side note about the end tidal CO2, because you're increasing your minute ventilation here at AT, this graph isn't perfectly accurate. You'll actually start to see your end tidal CO2 decrease at anaerobic threshold. And then because gas has to be in your lungs, your end tidal CO2 drops, your end tidal oxygen increases. If you want the exact reason why, you can look at this formula here. The air in your oxygen in your lungs is a product of atmospheric pressure, FiO2 that you're breathing in, and how much CO2 is in your lungs. So the lower the CO2, the higher your oxygen. The same reason why our super hypercapnic patient COPD comes into the hospital with a PCO2 of 80, they need oxygen at baseline. Okay. All right. Now, if this doesn't make sense, please ask me now, because pretty much everything is based around this. Yeah, anything? You're all lying to me, but I appreciate it. It's very nice of you. All right, so now we know this theory, and now we're going to pick our anaerobic threshold once we start exercising. Okay, so our lab uses the combined method, which is preferred. This is a fake graph that Dr. Morris made in one of his presentations that I'm using, that graphs your minute ventilation over your consumption of oxygen here, your minute ventilation over production of CO2 here. This is the respiratory exchange ratio, which is reported as the RQ in our lab here. And this is the end tidal CO2 here, okay? So if you remember what happens at anaerobic threshold, CO2 production starts increasing, that respiratory exchange ratio starts becoming more positive, the end tidal oxygen starts increasing. All right, so this is what we're trying to match. We're trying to match that magical point where the oxygen consumptions, this point where the minute ventilation over the oxygen consumption, because the minute ventilation starts increasing more rapidly, starts becoming more positive. The RER starts becoming more positive. The end tidal O2 starts to tick up. And this is that phase in that graph where now you're increasing your minute ventilation, so your CO2 actually can plateau for a little period of time. We call this isocapnic ventilation, and then eventually increase. Okay, so if everything works out perfectly, this is how the graph is supposed to look. We did actually have one this week where it looked pretty much like real life is supposed to. These are the colors are exactly the same. So this right here is the low point of the minute ventilation divided by the consumption of oxygen. The respiratory exchange ratio starts increasing at the same time. The end tidal oxygen increases at the same time. And for this person, it didn't plateau. It actually continued to decrease for a short period of time for the minute ventilation divided by the production of CO2, and then increase. So it's not perfect, but this was pretty good. Less good examples can look something like this. This is all the same patient, just graphed over different values. So over time, and this is also over time, but less values are reported, they average them. And this is per VO2. And you could at least try to convince yourself of a couple time points where the RER starts to increase and the VO2 starts to increase and this starts to increase, and it doesn't look exactly perfect. So this is just to kind of get you an idea. It's not always pretty. Okay. So let's talk a little about the normals. So as I referred to before, normal people when they exercise, it's a cardiac limitation. Either they reach a limitation of their heart rate, their stroke volume, their oxygen extraction into the tissues. They're able to get to a certain peak level of VO2, and then they have to stop exercising. Okay, that's ideally what normal things happen. Okay, you should ideally get to the heart rate that is about 90% predicted. There's a couple equations you can use. You can use this one. There's a different one that's mentioned in the guidelines as well. Your blood pressure should increase when you exercise. Systolic goes up. There's no magical how much it should go up by. It shouldn't get insanely high. And the diastolic should stay about the same or go up less than 20, okay? Since cardiac limitation is what you're gonna see in most people, they'll actually be able to increase their minute ventilation more if they were able to continue exercise. So they still have, a third or more of their minute ventilation they could increase, right? And you might ask me, like, where do you get these values from? Well, they got it from this one study in 1984 with Hansen and Wasserman with these guys. They had ship workers, and it was pretty interesting. They took 77 dudes. between 34 and 74. The rationale for why they did this is they said they did too many CPETs on healthy people before. That there's too many like athletes. So what do we do for our normal patients? We have hospitalized patients. Well, we don't do these on hospitalized patients. We have athletes. We have people who are not obese, people who've never smoked, and that's not real life. So they took these ship workers that were either healthy or they had hypertension, they were prior or current smokers, they were obese, and they had to have normal clinical history without cardiopulmonary disease, an x-ray that was normal or nothing more than pleural plaques from asbestos, normal PFTs, normal rest and exercise EKG, and normal reported exercise tolerance. And they put art lines in them all and exercise them. And this is, out of these 77 people, this is what they found is normal. They found that not a single person had an anaerobic threshold that was less than 40% their peak VO2. So they said that's abnormal. If it's below 40%, that's abnormal. This VO2 peak is what we use is from this data. They found that weight doesn't correlate with it really well. Interestingly, it's really age, sex, and height that determine your peak VO2, what it should be. All of these people were able to get to an RER of like 1.1 to 1.2. So they split down the difference at 1.15. It should be at least that. And then normal people are able to extract about 75% of their oxygen from their arterial blood to their venous blood. Okay, so if these are all the studies that were mentioned in the guidelines, the 2003 guidelines, which is funny when you think of 2003 guidelines, because we had 6-year-old data on pneumonia, and we were like, this is just outdated. How are we going to use this data? And this data is almost 20 years old now, and this is what we use. And it's citing studies that are even older than that. So we're not going to go through all of this, but this column here, I want you to look at this. These are the limitations that they cite. So every single one of these numbers is a limitation. It's too small of a study. It's retrospective. They didn't randomize it. They included smokers. They included different racial groups in the study. We didn't know how active they were. There was no quality control. There's no definition of confidence intervals. And then you look at the one that had the most, and this is the one that we just talked about. This had the most limitations that they listed. And the guidelines will tell you, yeah, this data is not very good, but we don't have anything better. So this is what we use. And it's pretty random. So these are what they reported as, these are what they suggest is normal in the guidelines for the 2003, which we won't go through. We'll talk about as we go. So a few more normal exercise changes. Your tidal volume should be increased as you go. It can get as much as 50 to 60% of your FVC, which is pretty big. If you think of some of these young guys who have 5 liters of FVC, they could, in theory, get a tidal volume of 2.5 liters to 3 liters. The dead space total will increase. There's some bronchodilation that happens normally as you exercise. So the total volume in your lungs actually increases, but since your tidal volume increases, the overall dead space should come down. You'll become more tachypnic. And then this, I thought this was a nice, this spirometry flow loop that you can look at. This is tidal breathing, this nice little circle here. And at end exercise, it's here. So this is getting closer to the FRC is decreasing, getting closer to RV. And the end inspiration is getting closer to the max of your vital capacity here. So you can see it just gets bigger and bigger. The FRC should decrease. We don't measure that in our lab, but you can. It should get smaller and smaller as you exercise. And then pretty interestingly, your oxygen, your heart rate and your cardiac output will increase pretty linearly over VO2 consumption, which seems odd to me that it works out perfectly. Not only your heart rate, but your stroke volume should, and your cardiac output should increase pretty linearly. There's an equation that we use based off the Fick equation. If you just take the normal Fick equation, divide both sides by the heart rate, you end up with this thing that we call the oxygen pulse. So you get VO2 over heart rate equals stroke volume times oxygen content in the blood. And in theory, when you exercise, this should remain relatively constant. Once you get at the peak exercise, you should be extracting as much oxygen as you're going to. Your hemoglobin shouldn't change over time. and your PaO2 plays such a small role, and it's probably not contributory. So you can ignore this part of the equation and say, if I take the VO2 currently divided by the heart rate, this is a surrogate for the stroke volume. So we'll be talking about that a lot too as we go on. Okay. All right, so this is a very easy algorithm, as you guys can see, of what they were using in a 1990 paper. I forget where this was from, but they reported it was more accurate than faculty interpretation and a good correlation with other algorithms that Wasserman put out, which is a guy that does almost everything CPET. I heard that name a lot as I was going. So I'm sure you guys have already memorized it because it's too easy, right? And then Dr. Morris came by and said, this actually is too easy, and we're going to help you guys to be better at it. And it's just a joke, Dr. Morris. I appreciate everything you've done so far. It's helped me a lot. But so this is what we do currently. We treat it more like a very complex PFT. We try to look for patterns that are abnormal and report those out, and then look at the actual patient and their data and see what could be explaining this. Very few times do we look at a PFT and say, this is the disease process that's causing it, without more information than just the numbers on the paper. And it's very similar with the CPET. Okay, so we're going to look at the pulmonary parameters, and we'll dive more into this in a little bit. We're going to look at the cardiac parameters, and before you get too far into the test, it's always important, did this person actually give us a good test? Do we have good data? Same as like a PFT and our DLCO. Is it reproducible? Is it reliable? Well, you're not going to have the person do 2-3 CPETs in a week to see if it's reproducible. So there's no real good gold standard here, but you want to see that your person isn't this guy on the bike here just flowing down. That respiratory exchange ratio, if you remember, we talked about it gets higher and higher towards you get to maximal exercise. So that can be a surrogate. Did they get to maximal exercise? Did they get higher than 1.1, 1.15, 1.2? Did their heart rate plateau? Did it get up to that 90% predicted? Did their VO2 plateau to where they can't consume any more oxygen? And did they say they were actually exhausted on the Borg scale? There are caveats to all of these. People with myopathy may never get to a point where they can get their RER up to 1.1 or even 1. People with cardiac disease may never be able to mount a heart rate high enough. A lot of people don't plateau their VO2 from what I've learned this week. And then people can be much more subjectively exhausted than they may actually be on the CPET. So these are all just like things you should put into context together. And someone will probably be watching them on the bike too and see. So we dive a little bit deeper into the pulmonary ventilations, kind of break it down, and do they have a mechanical ventilatory limitation? So we look at their minute ventilation, we look at their tidal volume, we look at their respiratory rate. This person over here was someone we did this month. This blue is their tidal volume over time as they increase their work. The red is their respiratory rates, and was that cyan or something like that is the end tidal CO2. So you're seeing their tidal volumes increasing over time. This is about, looks like 500, and it got up to about, I don't know, what is it, like 1.3. So that's more than double. That's great. We can look at the absolute numbers that are reported for their minute ventilation and what we would expect. There's some maneuvers you can do for people where you have them breathe in full tidal breaths and breathe out like they're doing a FEV1 procedure for spirometry. You can have them do that for 12 seconds and then multiply by 5 to get the max minute ventilation. Or you can just take their FEV1 and multiply by 40. May not be reliable in people with neuromuscular disease if they keep getting weaker with each breath, but it works pretty well. So that's what we use. What else? If someone starts to get bronchospastic after exercise, their FEV1 will be lower, so you might have to use that FEV1 instead of the pre-exercise one. But we'll get some magical number that's their max predicted minute ventilation. We'll find out what it actually got to during exercise, and did they have an acceptable amount of reserve. So that Wasserman paper said 71% plus or minus 15%. So did they have at least 10% breathing reserve? Could they have increased their minute ventilation at least 10% to get to what we predict is their maximum? Did their tidal volume increase at least 2 times? Maybe 2 to 6 times, but at least 2 times. And we'll look at the respiratory rate. You're not really supposed to get more than 50 per minute. If you start to get to 60 per minute, you're not really doing effective breathing there. That's very fast breathing. And something's abnormal with something in your lungs that's causing that. You can look at the action stat. Is it decreasing throughout exercise? Did it get to the point where they're actually hypoxemic that could limit their exercise? And this equation is supposed to help us kind of get an idea of dead space ventilation, which we think of as a non-invasive surrogate marker, this minute ventilation divided by the production of CO2. You can think of this as how efficient your lungs are. So if your lungs are really efficient, you increase your CO2 a little bit, you'll increase your minute ventilation just that same little bit, you'll breathe it off. If your lungs are not very efficient, you'll increase your CO2 a little bit and your minute ventilation will increase a whole lot to blow off that extra CO2. So since this is the minute ventilation divided by the production, the more positive this gets, the more abnormal it is. And you could even, if you had an arterial line in people, you could measure this directly. Dr. Roulette talked about before measuring dead space and critically ill. It's the same idea. You need a PaO2 and an PaCO2, excuse me, and an end tidal CO2, and you can find out their minute ventilation. Okay, but you shouldn't really have to put an art line in everyone, so we try not to. So we use this non-invasively. You could at least theorize how some people could make this number go higher without actually having problems with their lungs. If someone is extremely anxious and they're hyperventilating, the minute ventilation itself will increase. So this whole number will become bigger and they could look like they have a dead space ventilation problem. Okay. What questions do you guys have about this right now? So far? Okay, you guys are very good liars. All right, so if we take the same patient and we plot this graph over time, it looks slightly different. This is when she stopped exercising and her respiratory rate decreased and so did her tidal volume, but I'm gonna do some Photoshop magic here to say, what if she didn't stop exercising and she started to get more tachypnic and her tidal volume started going down? Is that something that you would expect is normal? Yeah, exactly. So you're worried about, is there some process in her lungs where she's not able to exhale fully? There's really no scenario where if you're continuing to exercise, your tidal volume should decrease as your VO2 goes up. That's not normal. Okay, so that's fake. But all right, what do you think about this person's ventilatory response to exercise, with the blue line being the tidal volume, or blue dots, red dots being the respiratory rates? These cyan are end tidal CO2, and this line is anaerobic threshold. So they're working the whole time, they start exercising, and then they get to anaerobic threshold, and then they're continuing to go. Do you notice anything that looks abnormal in this person? How about you, Matt? You're talking about this part here, right? Yeah, so she was getting pretty tachypnic throughout the point prior to increasing her tidal volume. That's not productive. What was that? Yeah, I would think so. I would think that's possible, or it's just some pattern of breathing that they're doing that's not productive. If you just increase your respiratory rate without changing your tidal volume, that's not going to help dead space. It's not going to be productive ventilation. So that's what we think. And as soon as the anaerobic threshold hit, they started breathing much more normally. Their tidal volume increased nicely to a certain plateau. And I'll let you know that this that was their predicted maximum. And then they got more tachypnic until they finished exercising. All right, so let's do a little example here. All right, so we got a 66-year-old guy. He's got COPD, he's on triple therapy. His FEV1's low, so is his FVC, his DL's low. He is still dyspneic, and you want to see why is he dyspneic, so you exercise him. He's able to get to 65% of his predicted VO2. We know that's not normal, it's low. His AT was greater than 40% predicted, so we're going to say that's normal. And he stopped because he was very dyspneic. Okay. His minute ventilation was 34 at peak liters per minute. The VE VCO2 was 44 at AT, which if you listen to Wasserman's paper, this was never normal. Greater than 40 was never seen in a normal patient. SpO2 was 93%. It dropped at exercise. And post-exercise, we did a spiro, and his flows didn't really change. So my question to you guys, did he meet any pulmonary limitations? So first, if we wanted to figure out if his minute ventilation was maximum, there's some kind of calculation you have to do. If you tell me what it is, I'll tell you what the number is. So you don't have to actually do the math. Yeah, so FEV1 times 40 is what we predict his maximum ventilation is. That number comes out to 35.2. So if you compare the 35.2 to what his minute ventilation actually was at peak, what does that tell you? You got like right at his max, right? So if that's his max, can you go any further? No, so that's not normal. You shouldn't have that. You still have like 20 to 30% left. So he reached a mechanical limitation with his minute ventilation. He couldn't go any further with his breathing. If we look purely at the numbers here, there's a problem with his dead space. It's higher than we'd expect. He got hypoxic with exercise, hypoxemic with exercise, so that's not normal. So we could say there's at least 3 pulmonary limitations here. He had problems with his ventilation, with his oxygenation, and his dead space. And if you look at his graphs over here, he's got a pretty decent AT right at this spot. I can't remember why else I put this up. Oh yeah, I remember. Okay, so this is his tidal volume here, and this is his respiration rate. So you can look here at, started off at about 1 liter. If we assume this is rest exercise or prior to exercise, and then at peak exercise, he got to about 1.4 liters. So he wasn't able to double his tidal volume either. So kind of just some patterns we saw. All right. So if you got this guy in front of you and they're meeting a ventilatory limitation, they're meeting they have increased dead space ventilation, or they're hypoxemic with exercise, what type of things are you thinking about with their problems? Well, ventilatory limitations, you know, we're pulmonologists, so those are easy to think of. Something with his diaphragm is abnormal, something with his lungs are as normal, something with his chest wall is abnormal. Those are pretty much the only things that it can be. So obstructive, restrictive lung disease, chest wall disease, obesity, neuromuscular weakness, any of those that can cause a ventilatory limitation. Dead space ventilation, you kind of add in some issues because of VQ mashing involves perfusion. So you add in some perfusion components to what was previously with the ventilation limitation. So you're going to take that lung disease, add on cardiac pump failure, pulmonary hypertension, and keep on the myopathies there. And then hypoxemic, again, I don't need to teach you guys what causes hypoxemia. It could be anything, right? Anything involved with the lungs, pump failure, pulmonary vascular disease, shunting, or if you really get to a point where you can't reach your minute ventilation and you start becoming hypercapnic, then your O2 can decline. But typically, if we're going to be purists, people who exercise who have cardiac diseases don't typically become hypoxemic. So that's not classic. Not that it's impossible, but it's not classic. Okay. Questions about this stuff? No. All right. That's what you say now. We get to cardiac limitations. It's similar process. So we're going to look at the VO2 over work. This increases linearly over time, and we can get a slope of this and find out what the absolute value is. There's pretty interesting. It doesn't change over age, over gender, over heights. It's almost always supposed to be within this 8.5 to 11 range of normal. So 10 is kind of smack dab in the middle. Similar, what's the VO2 at AT? That's age predicted normals. Or if you look back at that Wasserman paper, less than 40% is abnormal. Okay. Oxygen pulse, which is our surrogate for stroke volume. Okay. We're going to look at stroke volume. Did it increase appropriately? Did it get to at least 80% of the maximum? And if we look at the graph of it over time, is it showing us scary stuff? There's different ways we can look at whether the heart rate response is normal. Did they get to their 85% predicted maximum? something called the chronotropic index that we'll look at later. And did their change in heart rates or change in work, did that respond normally? We'll talk more about that. And then EKG changes, I think, is pretty straightforward what you're looking at. We'll talk more about blood pressure later too. So if we look at this graph, this is a graph of their O2 pulse, which is in blue, their heart rates, and their oxygen consumption, which is the cyan line that you're not seeing well. It's mostly covered up. This is kind of very similar to how I think about the tidal volume. Should increase, probably about 3 times their base oxygen pulse to peak exercise. And you should see their heart rate and their O2 pulse increase linearly throughout exercise. Okay, so same thing with that other patient. This is over time, so they stopped exercising right here. This is rest. This is a pretty normal response so far. So rest, rest, rest. They start exercising. You see a quick increase in their O2 pulse, and then it starts to slowly increase throughout exercise, as does their heart rate. And then they terminated exercise here, so you can forget about it coming lower. But if we do our Photoshop magic again, and you see that their heart rate keeps increasing with time and their O2 pulse keeps decreasing with time, that's pretty scary. That's not normal. So things that you can look at there. All right, so another person here. How would you talk about this person's heart rate and O2 pulse with exercise? This is purely plotted per work, so there's no resting stuff here. This is like normal to you, abnormal to you. Are there certain things that would scare you? Do you notice any trends towards the end of exercise? Yeah, the O2 pulse plateaus here. Yep, this keeps going up. So during this section, pretty much here up until here, it's increasing as you think it would. It's going linearly over work for both the heart rate and the O2 pulse. And Danielle was right, it does start to plateau at the end with the O2 pulse. So that can be a few different things. The most concerning would be, are they not able to increase their stroke volume anymore, which could happen normally with exercise. I mean, there's got to be a maximum for everything, right? So even a trained runner can only increase their stroke volume to a certain point. And that may be, like we talked about, a normal thing that limits exercise. Or it could be more concerning, like they have a problem with their heart squeeze. I'll let you know, this person had a normal VO2 at their peak. So this was actually a normal limitation of their exercise. Okay. All right. So some of those weird things we talked about, the chronotropic index. This is kind of a fancy way to gauge how their heart rate responds to changing in oxygen consumption. This is the equation for it over here if you want to look at it. But another thing that increases pretty linearly with heart rate and oxygen consumption. So you divide these numbers up and you should normally get a value of 1, meaning that as my heart rate increases, or as my work increases, my VO2 consumption increases, my heart rate increases the same amount. And this is kind of a graph of stroke volume here that we talked about. Increase a little bit and then steadily over time and then recovery. So you can get some information from this that you may not get otherwise. If someone has a low chronotropic index, it can be from lots of things. It could be from being on beta blockers. It could be that they really are Usain Bolt and they don't need to increase their heart rate that much. And if you look at that in context with the stroke volume, it can give you some information. So if Usain Bolt was running, his peak VO2 would be normal, his stroke volume should increase normally, and his chronotropic could potentially be low or be normal. But if someone has a normal chronotropic index and a low stroke volume, you could see that with someone who potentially has a problem with their heart pump or even in deconditioning. So kind of combining those two things together might get you more information than either one of them separately. All right. This next one's a little bit of just kind of like something that I saw in a patient that I thought was interesting. It's a lot of words, you don't have to read it, but this patient got a left heart cath and a right heart cath as part of a lung transplant workup. They got this EKG purely because, like, hey, we're going to cath this person. We should probably have an EKG in the system. And had absolutely no stenosis, but had significant pulmonary hypertension. And their Woods units were elevated. So some precapillary hypertension here with a normal wedge. And then they came up to K17, they got a walk test just to see, how much oxygen they need. And then while they started walking, they started having a lot of pain and dyspnea, and they got an EKG up there. And this is 2 days later. So you could see that they start having some pretty significant T-wave inversions in the anterior leads and in the inferior leads. And this person obviously didn't have an MI because they just had a cath like 2 days ago and they had absolutely no stenosis. And their tropes were normal and their echo was normal. But just to think of something else that might not be purely ischemic, because when I think of EKG changes, I'm like, okay, just send them to cards and let them fix it. But this could actually be a supply demand mismatch scenario in certain patient populations. All right, I'm going to ask Eric a question here about this study. So this was a really random study that I found in 1985. They took 5 bodybuilders, so people with absolutely no exercise problems, and they put A lines in their brachial arteries. These normal healthy people, I don't know why they would do this. And they started having them do exercises. So they do single curls with the arm that doesn't have the A line in, or they do single leg press or double leg press. And they saw what happens with their blood pressure. And Eric, I want you to guess for me what you thought the maximum blood pressure that they saw was during this in these bodybuilders. Yeah, the max blood pressure. Yeah, it was actually higher than 480 over 350. So this is different than riding a bicycle, right? But it kind of just raises the question, is it really abnormal to raise your diastolic only by 20 or more? Again, these people were healthy and it's a different type of exercise. And this A-line tracing was really, really fun. I thought this was like the heart rate here because it's very regular. That's actually with each rep that this guy's doing of double leg press, and these little spikes are the actual blood pressure itself. You can see here, this is 400 and he peaks out here. So, but after he's done with his 4 reps, he comes down to about 140 over 80. So it's pretty interesting. I don't know. It has nothing to do with my talk today, but I really liked it. All right. So a similar example for a CPET who has someone with heart failure. So someone comes to you with known ischemic cardiomyopathy, their EF's only 25%, they're on medical therapy for it. They're still really short of breath despite all their therapy. So they get a CPET. They get a good exercise based off this. They stop because their legs are tired, which is something that you might commonly hear in cardiac patients, that they're tired. It's fatigue more than shortness of breath. Anyway, their peak VO2 was low. Their anaerobic threshold was also low. Their heart rate was 94% predicted. You can just forget about this. And then their delta VO2 over delta work was 5.1. So this was the normal, is close to 10. It's not normal. Their O2 pulse was 64% predicted. They had no dynamic EKG changes. Their BP at rest was 100 over 70, and it got up to 174 over 87. Here's the graph of her O2 pulse and the heart rates. And do you think that there was any cardiac limitation? So this is the other question. Yeah, is anyone brave enough to tell me what they think is going on? Or at least one piece of it. It doesn't have to be everything. Yeah, it not only does it kind of plateau, she didn't reach peak VO2, so that's not normal. And then her heart rate started increasing pretty rapidly after that, meaning that was her body trying to compensate. I can't increase my stroke volume, let's increase my heart rate. The blood pressure is fine. There's no problems with the EKG. This is abnormal for sure. We'll talk about some causes of that. But this is something that you might commonly see in someone who has heart failure or a cardiac cause of their reason for stopping a CPET, reason for having a limitation. Both of these things I stole actually from the 2003 guidelines. If you guys want to look at it for some reason, review the case, there's about 5 case examples you can look at. All right, so a little bit more in depth of they reached a cardiac limitation and why. So let's say their only thing is a reduced AT. So we're going to look at the Fick equation here, and pretty much anything in the Fick equation can cause a reduced AT. So if you think about that, it's heart rate, stroke volume, hemoglobin, which you should know prior to the test, and oxygenation. Okay, so hopefully you should know oxygenation throughout the test as well. You have the O2 pulse, you can look at their heart rate. So you think about heart dysfunction, myopathies, pulmonary hypertension, parenchymal lung disease. It's supposed to be parenchymal lung disease, not parenchymal disease. But the main thing is really cardiac causes, because the only thing that contributes from a lung standpoint is really the oxygenation. So if the oxygenation is fine, it really shouldn't be causing a problem with the reduced AT. And if you remember that cardiac patient that we did the example case report for, his AT was actually normal, which is something you may commonly see in people like that. So this delta heart rate over delta VO2, this is that how much does my heart rate increase per work? If it's really high, it's abnormal. Higher than 50 is thought to be abnormal. So you should be thinking about things like deconditioning, obesity, cardiac dysfunction, myopathies. Obesity is kind of an interesting thing here, because if you think about it, fat doesn't participate in work, so it doesn't consume oxygen when you're exercising, but you still have to supply that tissue with blood. So if you're increasing your heart rate more and more to supply places that aren't consuming oxygen, this ratio will go higher and higher. So that's one reason why obesity is on here. That's number that's about 10, the delta VO2 over delta work. If that's low, you're typically thinking about cardiac dysfunction. This is kind of a measure of metabolic efficiency. It's what's in the guidelines and how efficient your muscles are. So if it's low, it's usually from not getting oxygen to the muscles effectively, or some problem with the muscles utilizing the oxygen. And you can throw anemia on there if it's really bad. You can't get oxygen to the muscles that way because the hemoglobin is usually transported. The chronotropic index we talked about a little bit. So super fit individuals, you won't see that commonly. You shouldn't be doing CPETs in your clinic usually for super fit individuals. AV nodal blockers like beta blockers, other issues with cardiac medications, or a problem with the heart itself. There could be a conduction abnormality within the heart. This we didn't really talk about too much, but it's listed in Dr. Morris's kind of cheat sheet for us, so I thought I should throw it on there. If you're not able to increase your oxygen pulse throughout work, so this should increase linearly, like we talked about. Pretty much everything cardiac increases linearly with work. This is a surrogate for stroke volume, right? So is this problem with the heart or problem with the muscles itself? And then we're talking about this, which is a surrogate for stroke volume. You can see this isolated problem with deconditioning. You can train your heart a little bit, or with cardiac disease, or this I thought was interesting. If you really have that bad of lung disease to where you can't get to end exercise, it might not increase to normal. All right, so we talked about a lot of things right there. We'll just briefly touch on who we should do CPETs for. Commonly, we'll see them for 1 and 2 for people who we don't know why exactly. They have multiple reasons for being short of breath, and we're trying to figure it out. We're trying to see how far these people can actually exert themselves. But the cardiac people use this for prognostication for their heart failure people. And should they be considered for heart transplants? Should they be intensifying their therapy more? You can do this for pre-op people for evaluation before lung volume reductions, before lobectomies, pneumonectomies, and you can see, do they really need heart, lung, or lung transplants? And the number 7 I thought was really interesting. It kind of said like, hey, if this person really needs disability, they should be able to prove that they're disabled, which I don't know. It seems weird and murky. And if you want to do some further reading, Dr. Morris has some good lectures up here. And this one I put up specifically because I found my favorite comments in the world from Maja. I've done CPET tests, but I didn't found doctor who can understand results. And it just made me so happy, because this is right when I started reading about it. I'm like, I don't either, so don't find me. These are the sources I used. I will hesitantly open the floor for questions if anybody has them. Let's do it. No audio. I think that's old. Yeah, that was from when the button was red. So I don't expect you guys to know everything about this, but if you kind of use Dr. Morris's cheat sheet and keep that in the back of your mind when you're doing CPETs, I think it started to make a lot more sense by the time I did my 4th one. And then it probably won't make sense by the time I do my 6th one. So we'll see.